Today, I'm delighted to welcome Dr. Dayna Johnson, a sleep epidemiologist and assistant professor in the Department of Epidemiology at the Rollins School of Public Health, Emory University, Atlanta, Georgia. She received her doctorate degree in epidemiologic science from the University of Michigan and completed a postdoctoral fellowship in sleep and circadian disorders at Harvard Medical School and Brigham and Women's Hospital in Boston. Her research is aimed at understanding the determinants and health consequences of sleep health disparities by addressing the social and environmental determinants of sleep disorders and insufficient sleep, and by investigating the influence of modifiable factors such as sleep disorders and disturbances on various health outcomes. More specifically, Dr. Johnson's research quantifies the contribution of social, household level, and neighborhood level factors with objective and well-validated subjective measures of insufficient sleep using data from different epidemiologic cohort studies. Dr. Johnson has published over 100 peer-reviewed manuscripts and has been featured in several magazines, podcasts, and news programs for expertise in sleep inequities, sleep health, and sleep disorders. Her mission is to increase awareness around the importance of sleep and eliminate sleep health disparities. So it's my honor to welcome Dr. Dayna Johnson to the Penn State Clinical and Translational Science Institute's Translational Science Seminar. Welcome, Dr. Johnson.
Thank you so much for the very kind introduction and also for the invitation to share some of my research on intervention strategies. So the title of my talk is Intervention Strategies to Address Sleep Health Inequities. And so I have no conflicts that are relevant to the presentation for today. And so there are a few important points that I intend to make during the talk today. And I really hope that we can have some great discussion around some of these points. And so first is that sleep is an important determinant of health. So we'll talk about the data specifically in the public health context. Also, I'll discuss how there are racial and ethnic and socioeconomic sleep disparities, and really using an intersectionality framework, discuss the data around these different disparities. And then I'll talk about the different multi-level factors that contribute to sleep health disparities. For the presentation today, I will target a lot of the individual level factors, but do know that there are contextual factors that are shaping individual behaviors. And then lastly, I'll give some data, talk about a study that we completed in the last year, which we intervened on psychosocial stress as its point of intervention to improve sleep and cardiovascular outcomes. And so to start, sleep is essential. This is something that we all do every day, or we should do every day. And it serves a very important part of our lives. And here's a definition of sleep that I really like that was published a few years ago. And this definition reads that sleep is a non-negotiable biological state required for the maintenance of human life. So again, underscoring that point that sleep is necessary for our survival. And our need for sleep parallels those for air, food, and water. And so as an epidemiologist, I am very concerned and really focus my work on not only studying these different determinants and consequences, but also thinking about ways that we can raise awareness about sleep. And so part of this is also emphasizing how we know that sleep is as important as having a healthy diet and also engaging in physical activity. So in addition to this physiologic state, the biological state is also very important, a very important health behavior that we engage in daily and should be considered as important as diet and physical activity. And so our sleep is very much controlled it's really bidirectional with our circadian system. And so here's a figure that does a really nice job of showing a healthy clock, which helps to control our sleep-wake cycle and then other processes such as our blood pressure, also cardiovascular ability and muscle strength. And our circadian rhythms can be changed or altered according to other factors, such as engaging in shift work, being jet lagged, also aging and other lifestyle behaviors. And we just had daylight savings time, so do know that many of us are likely experiencing some alterations there. And so that can result in a disrupted clock, and that can lead to poor sleep quality. Also, hypertension, our blood pressure is on a 24-hour circadian rhythm. And so, a lot of what we're really doing in my group is understanding some of these factors that are really the results of social determinants such as shift work. And so, as I mentioned, this is bidirectional. So the behaviors can also improve circadian health, such as time restricted feeding, and healthy light exposure is really one of the central points to having healthy sleep. And so, as I mentioned, sleep is an important determinant of health. And there are several important things that occur during our sleep cycle. And so, our sleep is really important for our memory and learning. So, when we sleep, this is the time that our memories get consolidated. So, without that sleep period, it could really have a disruption in learning. And as I tell my students, this is why all nighters do not work in terms of you consolidating and really engaging in that learning process. It's also very important for our emotional regulation. So when you're sleep deprived, you tend to be a little bit more irritable. It's also really important for immune and inflammatory function. When we sleep, we have a boost to our immune system that helps us fight off different illnesses such as colds. There's a lot of data that came out around sleep and COVID at the height of the pandemic. And then also it's very important for our metabolism. So I showed you in that last slide that relation between sleep and circadian health, and how time restricted feeding can also help to improve circadian health. And so we have important things that happen to our metabolism. And also, just to state, sleep deprivation is also associated with obesity through different pathways. And so, for one, we know that when someone is awake longer, they have more opportunity to consume calories, which is associated with obesity. And then, additionally, there are important hormones that are secreted during our sleep cycle. And so, when we have a disruption there, there's an alteration in these important hormones, such as ghrelin and leptin, that control our ability to feel full, and then also our ability to feel hungry. So when that's altered, we can have a delay in knowing we're full and also feeling more hungry than what we are. It's also important for our cardiovascular regulation. This is when we have healing and repairing to our blood vessels. And then it's very important for our performance. And so we can think about that in terms of our everyday lives as academics or clinicians, but also think about that in terms of athletes, for people that are engaging in essential jobs. So our sleep is really important for our ability to perform well. And so there's also a life course perspective. So sleep changes across the life course. So starting with newborns who need the most amount of sleep, they sleep about 18 hours on average, up to older adults who need about 7 to 8 hours on average. But just a point here about future research, we do see that older adults sleep less, but their need for sleep doesn't necessarily change. It's likely the result of comorbidities and medications, but this is an important area of research. And then in terms of sleep architecture, so we alternate between non-rapid eye movement and rapid eye movement throughout the sleep cycle. So we go through this process every 90 minutes. And so typically non-rapid eye movement is the bulk of the sleep period, about 75%. REM consists about 25%. And so REM and our stage 3 are really important. That's the deep sleep that helps us. Stage 3 is our deep sleep, which helps us feel rested. But we see across the life course that there's less REM. And so we see that individuals spend a little bit more time in non-REM. And so those lighter stages is when we can easily wait. And so, again, this is just showing this change across the life course. And so, again, as a epidemiologist, a public health professional, a lot of my work is focused on understanding the determinants, but also understanding the trends in sleep disorders and the prevalence. And so we know that sleep disorders are highly prevalent, but they are largely undiagnosed. And just to go through some common ones, so insomnia is a condition in which there's a problem either initiating or maintaining sleep. We see that this affects about 30% of the population. And then for sleep apnea, I include a range here, but the prevalence is about 6% on average. But since we're talking about inequities, it's important to understand that the prevalence of sleep apnea changes based on racial ethnic group, gender, sex. Also, profession. We know that athletes, particularly football players, linebackers, have a high prevalence of sleep apnea because they have larger necks. So typically, this is a condition in which there's an obstruction in their airway that causes either breathe or complete stops in breathing, and this can happen several times per hour of the sleep cycle. And so for children, this can sometimes be the tonsils, so removing them can clear sleep apnea, but there's a number of treatments also. So periodic limb movements or restless leg syndrome affects about 10%, so having an urge to move your legs. And then for circadian rhythm disorders, the prevalence that's published is 3%, but I have a question mark here because I really question whether this is accurate because of the limited amount of research that happens at a population level in studying circadian rhythm disorders. And then when we move into the dimensions of sleep health, which I'll talk more about, short sleep duration, so receiving less than the recommended amount, affects about 40% of US adults, and then about 25% report having sleep difficulties. Now, these different disorders, as well as dimensions of sleep, are associated with quality of life, a host of mental and physical health outcomes, including mortality. And there's different pathways by which these different conditions, sleep conditions, can lead to these health outcomes, and it can operate through metabolism, inflammation, oxidative stress, and autonomic function, just to name a few. And so I really like this idea of sleep health. And so for a while, we were really focused on sleep disorders, and we talked about sleep duration a lot in the literature. But this conceptual framework was put forth by Dr. Dan Bicey in 2014 in terms of a publication to really think about sleep health as this multidimensional framework that can be adapted to an individual, social, and environmental demands that promotes mental and physical well-being. And so there's different dimensions, including regularity. How consistent is your sleep schedule? Are you going to sleep at the same time every day and waking at the same time, regardless of it being a weekend or a weekday? And then satisfaction is this really patient-centered exposure of how satisfied someone is with their sleep. Alertness refers to the wake time, how alert someone may be. And then the sleep timing, where in the day, in that 24-hour period, are you actually asleep? Efficiency, how much of the sleep cycle are you asleep? And then duration, how much time? And this is a scale that you can actually measure. And it's only a few items. You can put it in your study. And depending on where someone falls, so those that have higher scores, it's associated with better health outcomes. And so they even have a t-shirt that Dr. Buxton mailed me a few years ago that is promoting awareness around sleep health. And so, unfortunately, sleep is not equitable. So we see disparities. And so when we talk about a disparity, we are talking about a difference in one of those dimensions of sleep health that I mentioned. But the reason why it's a disparity is because it occurs on a consistent basis and affects designated disadvantaged populations. And so NIH has set a specific racial and ethnic groups, which we'll talk about, that are considered disadvantaged populations, but also in addition to those individuals that identify as sexual minorities, those that are from disadvantaged backgrounds socioeconomically, and then also individuals that live in rural areas are also considered a part of this definition of disadvantaged populations. And so for the purposes of this talk, when I speak about race, I'm thinking of race as a social construct, not genetic. which really serves as a proxy for social classification. So, how people are treated based on the way that they are presented. And so, really, it's a proxy for racism. And so, just to briefly review some of the data around racial ethnic disparities, we know that historically minoritized individuals have a higher burden of sleep deficiencies, more severe sleep disorders, and then for these groups, it tends to occur over a longer period of time. So, more specifically, it's an earlier age of onset that sleep disorders starts to occur. And so here is a table from a paper that I published in 2019, where we reviewed the state of the literature as it pertains to these different sleep dimensions within these groups that are considered disadvantaged per the NIH. And so across these groups, we found that Asian, Black, Hispanic, Latino, Native Hawaiian, and Pacific Islanders all had shorter sleep duration in comparison to non-Hispanic white individuals. At the time that we published this, American Indian and Alaskan Natives had longer sleep duration. Now, I talked about how short sleep duration is associated with adverse health outcomes, but there's also data that supports that long sleep duration is associated with adverse health outcomes, particularly depression. And so, in terms of sleep quality, the data were a little mixed for some groups, particularly Hispanic, Latino individuals. And this goes back to race as a social construct. So, depending on the experiences of the individual, how they may present, can determine their different experiences with sleep. So, for example, Hispanic Latino individuals that have darker skin, they may have more encounters of discrimination, and thus their sleep may closely mimic those that are Black or African American, while those that are lighter may have less experiences, and their sleep can mimic those of non-Hispanic white individuals. For Asian and Black individuals, consistently across studies, we see poor sleep quality. And so while these groups are all included less often in research studies, it's very clear that American Indian and Alaskan Natives and Native Hawaiian Pacific Islanders are included to an even lesser extent. And so for many of these dimensions, we were not able to discuss the sleep of these populations because they either were not included in these studies or the sample sizes were too small. Across these groups, we see more severe sleep apnea. And then also for insomnia, we saw mixed results for Black individuals, and I'll talk a little bit about that, but more severe sleep or insomnia for Hispanic Latino individuals. And so, again, as an epidemiologist, most of my work is focused on doing quantitative studies. However, I have learned over the years the importance of also doing qualitative studies to understand the findings that we are seeing in these quantitative studies. And the reason why this is relevant to insomnia is from focus groups that we've conducted as well as others, we see that Black individuals are less likely to complain about their sleep. But we know when we measure it, we see that they have a longer sleep latency, more wakefulness after sleep onset, and lower sleep efficiency. But what we're finding is that stigma around laziness is very much a concern. And there's also this unhealthy hustle culture that tends to be promoted. And so we see that they tend to, again, less often or report or complain about sleep symptoms less often. But newer studies are showing that there's actually more insomnia. And so, in terms of just quantifying some of these experiences and bringing back in that intersectionality, on average, we see about an hour difference. But if we look at race, ethnicity, and gender, we see that Black men have the shortest sleep duration, about 5 hours on average, and white women have the longer sleep duration, and that difference is about 2 hours on average. In terms of the prevalence of sleep apnea, it really depends on the group, but differences between 5 and 86% higher prevalence of sleep apnea. We also see more severe sleep apnea and chronic insomnia. And while there's growing research, there's a limited body that studies insomnia with short sleep. This is considered a more severe phenotype than insomnia or short sleep alone. And there's one study that shows that Black individuals have about a 67% higher risk of insomnia with short sleep in comparison to non-Hispanic white individuals. And then data show that there's about a twofold greater odds of delayed sleep timing for historically minoritized individuals in comparison to non-Hispanic white individuals. So it's important for us to think about what's driving poor sleep in these populations. And so based on the fundamental causes theory, it suggests that it's education and income. So let's look at some data. And so here is some data from a national representative sample. It's older data, but I'll show you a study more recently that's consistent. Here in this study, they looked at the prevalence of short sleep duration by occupation groups, professional support and laborers, and also by race ethnicity. The blue line represents Black individuals, the orange line, Latino, and then the gray line, white individuals. And so here we see, if we look within the professionals, is actually the Black men and women, particularly Black women even higher, who have the highest prevalence of short sleep duration, whereas the opposite is true for non-Hispanic white individuals, that laborers have the lowest, or the professionals have the lowest prevalence of short sleep duration. So we see the greatest difference is among those that are professionals, where when we look at the lower socioeconomic group, laborers, we actually see a much narrower difference in the prevalence of short sleep duration between Black and white individuals. And then for women, we actually see no difference. So we really see for professionals of higher SES that are Black or even Hispanic Latino, they have the same gradient, it's just lower than those for Black individuals. That it's those of higher SES that are most affected by short sleep duration. And so this greatest disparity is at higher SES, which really challenges this idea that it's consistent across other health outcomes that lower socioeconomic individuals have worse health outcomes. But we see a very clear intersectionality here, and thinking about these different identities, particularly those of higher SES that belong to historically minoritized groups that may be encountering unique stressors that are increasing their risk of poor sleep. And so that last slide showed occupation. Here's data using education, and we see a similar gradient. And so white individuals are on the left, Black in the middle, and Hispanic on the right. So we see for Black and Hispanic individuals, as they increase in education, we see that the predicted probability of short sleep duration also increases. However, we see the opposite for white individuals. So as education increases, you see a decrease, particularly for those in the college plus group. They have a lower predicted probability. And so while these differences are very small for less in high school and some college, we see a very clear trend here for Black individuals. So here we see that SES alone is not protective of sleep health for minoritized groups. So while we have learned from other groups, particularly in public health or for other health outcomes, that as you increase in your income and education, you can live in better neighborhoods, which give more, you have more resources for a healthy lifestyle. You also tend to have insurance and have more access to care. And so that should be associated with better sleep. But this is actually not true for Black individuals. We actually see as income and education increase and living in these neighborhoods with higher SES is actually associated with more stress and poor sleep. And so these individuals encounter more systems of oppression. And so you tend to be the only one in the higher SES within these different fields. So in your work environment, you may be the only person of a certain race, ethnic group, in a predominantly white environment. And so there tends to be more encounters of racism, also microaggressions. Also, living in these neighborhoods, we have seen where individuals such as Henry Gates from Harvard has been arrested or had police encounters on their doorsteps because the police didn't believe that they actually lived in those homes. So these different higher SES environments are actually increasing stress, although they may accompany other resources and income. And so there are several determinants of sleep and circadian disparities across the life course. And we see, as I previously mentioned, that social determinants are contributing, particularly discrimination and stress. And then there are also environmental factors. And so my colleagues and I have coined the term sleep deserts to really reflect these areas that are non-conducive to healthy sleep practices. So these are areas with more inopportune light exposure, more noise, more toxins, which are associated with adverse sleep health outcomes. And then we also see, despite individual level income, that those that are from historically minoritized groups are more likely to live in neighborhoods below their individual income. And then we also see that those that are in these higher SES neighborhoods, they are also more likely to sleep with light on as a reflection of safety measures. And then there's sleep-related behaviors, which tend to be shaped by broader context, such as consistent bedtimes, can really be the reflection of policies such as minimum wage, which is not a livable wage. So someone who has a minimum wage job may have to work several jobs in order to have a livable wage, and does not have a consistent bedtime. And so if we just focus on individual level behaviors, we miss that opportunity to address contextual factors which are determining these individual behaviors. And so these can individually and cumulatively contribute to disparities in sleep and sleep disorders. And so when I talk about these contextual factors, we're really thinking about a social ecological model, how individuals are nested within broader contexts. And so their individual behaviors and outcomes are dependent on the environments in which they live. And that can be that can reflect in their households and also their neighborhoods environments. And so this is just a conceptual framework that my colleagues and I published a few years ago, really showing this nested relationship of individuals in these broader factors and how it's important for us to consider all of these and how they can really affect someone's ability to accept and be able to engage in healthy sleep practices. And so here is a figure that the American Heart Association published a few years ago, which really showed this historical relevancy of how structural racism really leads to more downstream outcomes. So we talk about slavery, which happened, over 400 years ago, but we still see present day effects. And so this slavery has led to things like Crow laws and segregation redlining, which I'll talk a little bit about, which really determined whether neighborhoods were deemed worthy of investment or not and denied mortgages for some populations. And so that led to concentrated poverty and then these different social determinants of health. So it led to poor access to healthcare, poor housing conditions, poorly funded schools, and poor access to capital. And I'll show you an example of that. So living in these neighborhoods definitely have a generational effect, which we'll talk about, but we still see segregation persisting and these adverse exposures. Now, it would have been nice if the American Heart Association included sleep, but they did not. So I added this just to show that these different determinants are leading to an increase in sleep apnea, which is likely increasing risk of heart disease and stroke risk factors, also connected to toxic stress, which lead to worse cardiovascular and stroke outcomes. So let's, go through this example and thinking about these social determinants and how they continue to persist. So money determines where someone is able to buy a home. So if you have less money, you are more likely to live in a low income area, which per these different historical policies and laws and practices, bus stations and manufacturing facilities were placed in these neighborhoods. And so they tend to have more air pollution and also over policing. And so the taxes are typically lower because the house values are lower. And so we know that can determine the resources that are for the schools. So inner city schools have less resources, tend to have overcrowded classrooms. And so there tends to be lower educational opportunities. And so they have lower graduation rates. And so based on your ability to go to a good school, that can determine your upward mobility. And so if you are at a school that has lower outcomes, you're more likely to have worse outcomes. You're more likely to have limits on the type of jobs that you can work, which again determines your money, which then feeds back into this cycle. So where you live definitely matters for your ability of upward mobility. And so this is an example of the historical laws and practices, how it's contributing to present day segregation and limiting the upward mobility of many individuals despite individual level income. So this also contributes to this lack of generational wealth that many historically minoritized groups do not have. And so structural racism can lead to the residential segregation, as I explained, with inequities in resource distribution. And so that leads to differential access in housing, education, wealth, and healthcare. And we can measure and have studied the current day effects of pollution, violence, and disadvantage. And we know that these can get under the skin and we can have a physiologic stress response. These individuals also encounter more chronic stress. And then there's also adverse childhood experiences, which are associated with sleep and circadian health. So let's go through some empirical data around stress, and then I'll move into our intervention that we conducted. So stress is a contributor to sleep and circadian and overall health disparities. And so we know based on your race or ethnicity, this can determine your experiences with psychosocial stressors. We know that those that are historically minoritized tend to have unique stressors that are additive to the everyday stressors that everyone experiences. And so through some of our research, we have found that those that encounter discrimination during the day, they also tend to ruminate more at night about those experiences and have increased arousals. And so and we've tested this through mediation analyses and also have conducted qualitative studies to understand that more. And so we know that that's associated with adverse sleep health and then also consequently with cardiometabolic health. And so just to support some of that with evidence, here is a figure from a paper we published where we looked at racial discrimination as a mediator of racial disparities in insomnia severity. And we found that 57% of the racial disparity in insomnia severity was explained by racial discrimination. And then additionally, here's some data from a epi cohort study called Cardia, where we looked at the burden of stress. So not just experiencing stress, but how much of a burden is the stress that you have experienced in the last 6 months. And so here we, in our sample, were Black and white individuals. We looked at tertiles of chronic burden in relation to actigraphy measured sleep, which is our objective measure of sleep, and self-reported sleep outcomes. And we found associations only among Black individuals. So in particular, those that experience medium or high chronic burden, they had greater than a twofold greater odds of self-reported short sleep, sleeping less than 6 hours on average, and then also twofold greater odds of poor sleep quality as measured by the Pittsburgh Sleep Quality Index. There were no associations among the non-Hispanic white individuals. So again, underscoring chronic burden as this unique stressor for Black individuals. So here's some data from a study that we conducted looking at gendered racial microaggressions and different dimensions of sleep health among Black women in Atlanta. And so here we found that those that encountered or experienced gendered racial microaggressions, these are these subtle um, um, discriminatory sayings and acts that people can experience, such as congratulating folks on getting a PhD, for example, as well as others assuming different things about them because of their race. So here, after adjustment for confounders, we found that those that had experienced gendered microaggressions, they had a 52% higher odds of poor sleep quality, also a 33% higher odds of a longer sleep latency of 30 minutes. And then we were very interested in understanding what may be explaining some of these associations. So in using a sequential model adjustment, we adjusted for depressive symptoms and worry, and we did see that the association was attenuated, but it's still maintained. And so from these different studies, it really underscores this need to intervene on stress. So where we currently are in the literature, we know that there are sleep disparities. And there's an understanding of this relationship that sleep disparities, between sleep disparities and racial disparities in health. So there's data showing that racial disparities are contributing to overall health disparities. So again, if we can intervene on sleep, we might be able to reduce overall health disparities. And so it's important for us to start exploring interventions. And so I'm going to show you some data from a mixed method study, and I'll pull from two different studies. So here's some data from the sleep health study that we conducted in Atlanta, where we did focus groups to understand some of the facilitators and barriers to healthy sleep. And so when we asked participants, and so these again were Black men and women and also gender nonconforming individuals that participated in these focus groups. And so here, in terms of barriers, which I'll focus on, here were the most common that I highlighted here. Individuals in these groups reported some of their most significant barriers were stress, anxiety, rumination, feeling unsafe, and past trauma. And so there are others that were mentioned, such as unsuitable sleep environments and other broader environments, but these individual factors very much were common in the results. And so there's data that shows that meditation strategies are effective at combating stress. And so there are studies that have shown that so individuals that engage in these practices, they have less stress and anxiety. Also data that shows that there's a higher sleep quality among these individuals. However, there's also some gaps in this literature. So these studies tend to have a lack of diversity. And so we really have no data around how feasible that these studies may be among larger groups that are considered racially minoritized groups. And then also understanding whether or not there is an impact, a subsequent impact on cardiovascular health. And so we conducted the MIND study, which was really aimed at improving sleep and diabetes risk via a mindfulness and sleep education intervention. So we enrolled 18, this was a pilot study, and really a feasibility trial. 18 men and women who lived in Atlanta that were over 18. We targeted those with poor sleep quality using the PSKI. So, and I'll show you, they went through a 30-day mindfulness meditation meditation intervention, and also had some healthy sleep tips. And then we monitored their sleep using an ActiWatch. And so we did 35 days of actigraphy. And this was conducted, it started during the pandemic. So during that time, we were dropping off scales and blood pressure cuffs. Originally, our design was to bring people into our research space, but we weren't able to do that. And so at these different time points, they completed a variety of questionnaires. And so here's an overview of the actual mindfulness intervention. So we use the Headspace app, which was really great for doing research because Headspace has a research sector. And so you partner with them and they're able to send us the data directly. And so we were able to monitor this. And so we asked participants to complete about 10 minutes of mindfulness each day within 2 hours of bedtime. And so here are the specific sessions that we asked them to do. The first few were generally just about different breathing exercises and how to relax. And then the last few were targeted at managing anxiety and letting go of stress. And so then I did a healthy sleep practices really conversation with the participants in a group setting, really leveraging some of the work that we did in Boston using this specific schematic where we really were educating individuals about the time of day where they should and should not engage in different behaviors. So emphasizing getting light early in the day, decreasing light at night, no naps, caffeine, or alcohol use close to bed, and no electronics in the bed. And so at baseline, we started actigraphy, measured their weight and blood pressure, did questionnaires, and then we had the intervention visits. On average, it was about 5 days later. And then at the midpoint, we downloaded their sleep data just to make sure everything was collecting fine, did a number of questionnaires, measured weight and blood pressure again. And then at the end of the study, we repeated all those same measures. And then we also did focus groups in the end to understand more about their experiences. And right now we're working on the larger grant, which is a clinical trial focused on this, which we're submitting in June. So I would love to hear any thoughts you have about this. So on average, it was a pretty younger population. The average age was about 30. 89% of our sample were females, and the majority of our participants belong to a historically minoritized group, either Black, Asian, or Hispanic. And it was very much a highly educated sample. So you see over 80% of our sample had either a bachelor's or a professional degree. And so one of the parts about doing research in Atlanta is the SES diversity of Black individuals here. And so that's definitely reflected in many of our studies. And again, since I showed you that data earlier, that poor sleep is most common among higher SES than lower SES Black and Hispanic individuals, we definitely wanted a broad SES gradient, but we ended up getting more that were on that higher SES. But despite their education, we actually see that less than 50 or about 55% of our sample had less than a $50,000 income. And so in terms of app usage, and so again, they used the app for 30 days. We asked them to do about 10 minutes on average. And so we see that people completed about, on average, 37 sessions. They were only asked to complete about 30 sessions, but there was pretty broad range. On average, they spent about 23 days utilizing the app. It spent about 9 minutes, which is great since we were aiming for 10. And then 33% were adherents 30 days for all 30 days, and then 44% for 66 days. So here I'll just show you, again, it's a small sample. So this is really showing you the distribution. The blue line is, or the blue bars are before the intervention. The orange is after the intervention. So we see that the distribution of those in the high stress group decrease after the intervention. We also see that more individuals had lower stress after the intervention than before. So we see this change in stress. In terms of sleep quality, we see that there was a decrease in the Pittsburgh Sleep Quality Index, which means sleep quality improve. Higher scores are associated with worse sleep quality. And so to quantify that, so the cutoff is 5 for poor sleep quality using the PISCI. So we saw a change of 67% at baseline and 39% when we did the follow-up 35 days later. In terms of sleep duration, there were very minimum changes, but here I'm showing you the self-reported and the actigraphy to show you how much of a difference it is depending on how you measure sleep. And so again, there was really no difference, but people were reporting they were sleeping about 8 hours. And as you can see, they were actually sleeping about 6 hours on average. And so you see these really slight increases, but again, sleep duration didn't really change. But again, just seeing this big difference in how people report their sleep and how their sleep actually is once we measure them. And so in terms of sleepiness, we saw a decrease where on average, the score was 6.1 at baseline, and at follow-up, it was 5.7. So it's a smaller change, but people are reporting less sleepiness, which is great. And so, so this figure just shows the prevalence of the stress level, sleep quality, and sleep duration by adherence. And so there's not really much of a difference here across these different measures. And so again, because of this small sample, we weren't expecting to see cardiovascular changes. We really were more interested in testing whether or not it was feasible to measure these across time. But surprisingly, we saw a difference. So the prevalence of obesity decreased from 50% to 35%. So again, we're talking about just 35 days. And then we also saw that more people were in the normal blood pressure group. So an increase from 78% to almost 89%. And so again, this is an individual level intervention. And so we saw that engaging in mindfulness was associated with less stress and anxiety. We saw an improvement in sleep quality and also an improvement in cardiovascular health. And so going back to some of the qualitative data, and so we brought these individuals in. So these are actually individuals from the sleep health study, in addition to mine, to understand more, but only the African American participants to understand more about what do you want out of a intervention study, or really what are some of the targets and the ways that you prefer to receive information about how to improve sleep. And so overwhelmingly, participants said they want data from social media. And so when we probed a bit, they identified these other sources, news, a doctor professional, websites, other patients, but they were really like, we want our information from social media. And it doesn't have to be a professional that's giving that information. And so they underscored the importance of disseminating information through videos and graphics, a little less about printed materials, but they did say pamphlets were nice, but they really want information through different videos. And so when we ask about what's really important in terms of this dissemination, overwhelmingly across these different focus groups that we did, and we had about 5 different groups, the most important was racial tailoring. They reported wanting information from people that looked like them. They talked about brief messages so they can understand the point quickly. And then they also wanted more information about how sleep was important. And many, despite their education level, did not consider sleep as, that's important to their overall health. And they talked about the need to design this for lay audiences, and then this mode of widely disseminating this information. So again, through videos and so on that could be used through social media. And so I want to end with this graphic, which talks about different upstream and downstream factors, really as this place of how to target interventions and so on. And so, of course, I didn't include sleep, so I had to add it here. We talked a little bit or a lot about these downstream, behaviors of risk behaviors, disease, and so on. But we know that they are really determined based on these upstream factors. And while I share data about these individual level interventions, it's really time for us to move upstream and understand how our behaviors are being shaped by the context in which we live. And so I want to end with just showing this busy schematic of an intervention that we are currently doing. It's being led from a group out of Michigan. I'm leading the sleep piece. And here we're really focused on understanding extreme temperatures and how the household may either promote or hinder healthy sleep and health and different health outcomes, particularly cognitive function. And so here we are evaluating sleep and health outcomes before and after people have their homes weatherized. And so this is just showing the different exposures that can come from the outside and also measures from inside the house and how there's economic consequences and or benefits and thinking about utility, usage and cost. And we're looking at how these can go through these different pathways to affect sleep and cognitive function. So in summary, we see racial and socioeconomic disparities in sleep. We know that minoritized groups are disproportionately affected by these different stressors. And so targeting stress may help to improve sleep in minoritized groups. As I showed you data that from targeting stress, we were able to improve sleep quality and some cardiovascular outcomes. And then there's this need for multi-level, but also tailored interventions. And while I didn't have time, we're ending and I want to make sure we have time for a Q&A. There are other studies that have shown the benefit of race concordance and intervention studies, particularly cognitive behavioral therapy. They have shown that using individuals as of the same race increases engagement in these studies. Also, there's data showing shut-eye, which is a common sleep intervention, that Black individuals are more engaged when the patients and physicians are of the same race. So I just want to acknowledge some of my colleagues from the work that I shared today and my funder. And we have about 5 minutes for questions, but you can always email me. I'm happy to continue to engage. So I want to make it larger so I can see everyone, but I'm happy to take questions.
Thank you, Dr. Johnson. That was fabulous.
Thank you.
Somebody had to go, but had asked an earlier question. In your earlier disparities related epi description of broad categories of sleep issues, sleep health issues, were those single race individuals in your analysis?
Oh, okay. I wonder which study they were talking about. So for the ones that were mediation, they were not. We included several racial groups, but a lot of my work is conducted within groups. So I would need to know which study.
The first one where you had limited information for Native Americans and Hawaiian Pacific Islanders. In that one, were each of those groups, it was one of the first things you showed, were in each of those groups, were those single race individuals or were they mixed?
Oh, great question. So that was a review paper. And so the way we devised the study was to report on these categories. So it just really depended on how the original empirical study was reported. But it's really interesting that you're asking about mixed race. And so what we typically, in the studies that we do, we ask people all the identities that they belong to. And so, but from our experience, so again, we're using race as a social construct. And so we find that we're also measuring discrimination. So even if they're of mixed race, their experiences are still of those that of encounters of racism and discrimination. But we do collect that data and have reported it. And so I'm happy to send you that paper also.
Thank you. Another participant asked, do you find the SES impact on sleep impacts children as much as adults? Are children more vulnerable, less vulnerable?
That is a really great question. So, depending on the measure, so for example, neighborhood socioeconomic status, I'm actually saying that children are more vulnerable to their environments than adults are. So, we consistently see that neighborhood disadvantage is associated with sleep apnea among children, but we do not see those same consistent results for adults. In terms of when we look at household measures, so similar to the gradient I showed you for SES and race being more of a problem among those that have higher SES, we also see that for studies in children and adolescents, so specifically using Ad Health. We published a paper, I think this past year, that even children that are in that study, it was Black, Hispanic, Latinx, and I believe Native Hawaiian Pacific Islanders. So I believe that was the other group. Those individuals who lived in households of higher SES, they had worse sleep than in comparison to non-Hispanic white individuals. And we also saw that household SES mediated the racial difference in sleep duration for adolescents that were in that study. And association was most pronounced among Latinx individuals. And so yes, we are seeing that for children it can be more vulnerable, and also based on data that shows that childhood sleep is predictive of adult sleep. Underscores this population is high risk and the importance of doing these studies in those populations.
Fantastic and fascinating. For the obesity decline, that was a really big percent. So must have been
Yeah.
some people near the borderline. Do you have the mean weight decline in those 35 days offhand?
I don't remember offhand, but I'm happy to share that
Okay.
via email.
Okay. Just
Yeah,
curious.
but that's a good, yeah, no, that's a really good question.
For the translational science seminar perspective, I also will just emphasize how important it is, this thinking about moving upstream and those kinds of translational interventions around structural factors. In fact, I thought that was so important, I'll share with everybody else and put you on the spot, that I asked
Yeah,
Dr.
yeah, please.
Johnson to lead a special issue on sleep deserts for the journal Sleep Health. So if any of you are considering that, she will soon be overseeing that
Please.
endeavor. So thank
Yes,
you for your
yes.
leadership in sleep health.
Absolutely. Absolutely. Thank you. And again,
Mhm.
I'm happy to engage over email, and I'll actually send you two of those papers that may be helpful for the person who left early.
Okay,
Um, or you can send me their email. I can send it to them either or.
sounds good. Any last questions
Thank
from the
you.
audience? Thank you again, and
Oh,
we'll be in
thank
touch.
you. Thanks so much. Have a great day.
You too.
Bye.